A very warm welcome to everyone. So, today we have a case of a 45-year-old female who presented with the complaints of gradual abdominal distension. She had low grade fever, and on examination, we could see free fluid in the pelvic cavity as seen here. Initially, it was thought to be tubercular because the patient has had exposure of tuberculosis from her husband. The husband had pulmonary tuberculosis and was getting treated for the same from the last 6 months. This patient also revealed some pleural effusion on both the sides with collapse of the right lower lung segments. So, initial workup and diagnostic workup was done, and the patient was thought of having abdominal tuberculosis as of that time. But to our surprise, there was an increased CA125 levels. Again, on the imaging, we thought we could see some adnexal lesion. So maybe this was an ovarian malignancy because of the raised CA125, but we could not see any obvious ovarian cause, no obvious adnexal lesion which could point out to that direction. So the next thing which could have been done by everyone, we went for an ascitic tapping, and an ascitic tap was done. So at this point, we thought our diagnosis would be confirmed, but to our surprise, it made the whole situation even more confusing because it was not confirmatory of either of the pathologies. There were some atypical cells seen in the fluid, but there was no confirmation for the same. So when the fluid cytology and the AFB smear gave an intermediate and negative etiology, then our concern shifted to establishing the diagnosis, because as we understand, if the patient had ovarian cancer, then the treatment would be much different than if she had tuberculosis. So at this point, what we did was we revisited the imaging and we tried to figure out from where we can take the sample. As you all understand, the ascitic fluid retapping was out of the question. We wanted to get a definitive diagnosis. So at this moment, I would like you to pause this video and reassess the imaging and see where the sampling could have been done. So if you scroll a little bit higher cranially, you will see that we can see some suspicious nodes here. See, let's zoom it. Let's change the window a little bit, and I think now we can appreciate them a little bit more. That there is a lymph node here and a lymph node here, and similar lymphadenopathy can be seen in the pericardic region. Yeah, this was missed on CCT abdomen, and the patient had to undergo a PET-CT, which showed that these nodes did had an increased FDG uptake, and now these nodes were selected for a biopsy sampling. So what we did was we targeted this particular lymph node, and we thought that okay, maybe we can take a sample from this particular area and establish the diagnosis. So as you can go and see the supported videos, an ultrasound guided biopsy was done, and to our glad, it came out to be tuberculosis. The patient was started on anti-tubercular therapy and it showed promising results. After 3 months, she was recovering well, and the ascites was gone. The lymph nodes have shrunken in size. So the point to be noted here is that in cases of suspicion, one should always go for a histopath examination and try to establish the diagnosis, because otherwise there might be situations where a different kind of therapy can be provided to the patient, which is not at all useful to the patient. As you can see, malignancy has a very different approach as compared to the tubercular approach. So thank you, have a nice day, see you in the next case.